Again, on behalf of AMAAC and CRG boards, we are welcoming all our group and participants in our second course today, where we are going to talk about the key updates in the treatment of metastatic breast cancer. So just some points to the attendees to note that it's recorded, and regarding the certificates of the previous activity, the organizers will send an email with the certificate and the link of the YouTube if they want to attend it again. So if you have any questions, so you can raise hand, make your presence known. Participant, raise your hand for questions and comments, and we will give you the privilege to talk. For the question and answers, please share your questions in written in Q&A section, and we will try to address them all. I would like to thank the sponsors and the supporters of this activity, Roche Company, Pfizer, Newbridge, and ESI. I will introduce my first speaker, who is going to talk about case introduction, Dr. Marwan Ghosn, who is professor and chairman of Hematology Oncology Department, Faculty of Medicine, St. Joseph. Please, Dr. Marwan Ghosn.
Dr. Marwan? Marwan?
Yes, sorry for that. Again, I tell you, thank you very much, Dr. Sami Khatib and Dr. Farhat, and for all the organizers for organizing this very nice activity, which bring us all together through the webinars is this very difficult time of COVID-19. And I was also saying that there has been a slight modification in the program. And in fact, I have a direct presentation. This is what I have been asked to do, a direct presentation for which directly I will begin. And I just need to get the screen. Please, can we go back one? Can we go back one slides, please? Can we go back to the first slide, please, of my presentation? Okay, very much. Thank you again. Can you give me back? Okay, I think that I have back the key control. So I have been asked to begin this webinar by a small presentation on the burden of advanced metastatic breast cancer, and to share with you the experience of one single particular CDK4, CDK6 inhibitor in advanced metastatic breast cancer. Next, please. Okay. As you know, I am from Beirut, Lebanon, and this is my dearest Faculty of Medicine in Beirut. This is how it looks like nowadays before entering into summertime completely. We didn't have the opportunity to hang around these recent days because it was closed all the time, but hopefully we will come back together very soon. So this is a disclaimer, and of course this is a supported lecture by Pfizer, but I only view it, and everything I am saying is under my own responsibility. So let's go and have some epidemiology and treatment landscape of metastatic breast cancer. We'll go afterwards to a pooled analysis of all the CDK4, CDK6 trials. will say a few words of three experience of palbociclib in real world evidence, and we'll go back and have some take home messages at the end. So let's have a look on on the epidemiology and treatment of metastatic breast cancer. Okay, the metastatic breast cancer, you know, is the most common invasive cancer, as you know, globally in women, and it accounts for nearly 2 million plus the new cases of cancer per year, which is around 25% of all cancers. And let's take, for example, in the United States, roughly 20 to 30% of women who had early disease will develop advanced breast cancer, and it is something like 150,000 in the United States. Among them, 60% of those patients will be hormone receptor positive and HER2 negative. 17% will be both HER2 positive and hormone receptor positive. Around 9% of the cases will be only HER2 positive and hormone receptor negative, and around 13% of the cases will be triple negative. Breast cancer in males will account for less than 1% of all breast cancers. The survival of breast cancer, as we know, in distant, so metastatic cases, is around 25 to 30% at 5 years survival. So it is really a very low survival for those patients, meaning that we need to have new treatments for those patients in order to get a better survival. Among the latest treatments were the introduction of CDK4 and CDK6 inhibitor, and these were pooled in trial analysis. And this is the pooled analysis which was published during ASCO 2018, where data from 5 phase 3 trials, randomized, controlled treatments with CDK4 inhibitors, with either aromatase inhibitor combination with CDK inhibitors as a first line, or fulvestrant in second line settings. All those were pooled, and the median investigator assessed the progression-free survival, and it was examined using the methodology of KM plots. So if we go to the intent to treat population in aromatase inhibitor and in fulvestrant, you know, the pooled analysis was around 3,002 patients. 3,002 patients, and the CDK4, CDK6 inhibitor progression-free survival was 20.5 months versus 11.8 months in the placebo. So I will only look at this figure just to tell you that the hazard ratio was an impressive 0.59, and definitively the use of CDK4/6 inhibitor either in the first line or a second line yielded better progression-free survival for those patients. So when the FDA pooled analysis was given, it was supported in summary that the addition of CDK inhibitors confers similar progression-free survival benefit for all studied subset of patients when the subset of patients were seen, and hazard ratio was comparable to those for the ITT population. The benefit seen in first line setting with aromatase inhibitor, and also it was seen in a second line setting with fulvestrant. Exploratory statistical analysis with all the subset variables found no evidence of treatment effect interaction, and the natural history of disease and the magnitude of CDK inhibitor benefit was similar for certain subsets previously thought to have different behavior, like globular cancer or more indolent and endocrine sensitive, versus PR, for example, negative, as more aggressive and less endocrine sensitive. But of course, there was the study strengths, which was the analysis of raw patient level data for all FDA-approved CDK inhibitors. And it was a pooled analysis allowing for increased patient size for each studied subgroup. And the major study limitation was that this was a cross-trial pooled and subgroup analysis. It was not a randomized trial. The granularity of information depends on the information gathered by the sponsor and varies between registration trials. And the results can be used as hypothesis generating only. If we look into the palbociclib real-world evidence, let's go to the clinical evidence. Everybody knows the trials, but let's go into the real-world, use of the drugs. All the times, we clinicians, when we look into the trials, we see and we say that patients included into clinical trials are very strict inclusion criteria for these patients. And all the times, we clinicians, we are asking the question, can we reproduce the same data on our patients, the patients that we see in our clinic, and not only the patients which respond to only very strict criteria. For that, the methodology of real-world evidence generation has been developed and highly encouraged by the third-party payer and the government and the bodies of of the legislation. So usually you go and you have a data source, which is usually either the data of the clinics, of the patients or the hospitals, and you process the chart, you audit the chart, you extract the data, you can have some Q and answers when you get the data, and you need to have a natural language in the processing. The data requirements needs to be of high quality, needs to be complete, needs to be transparent, needs to be generalizable, timely, and scalable. And all those can be used for research, for clinical use, and also for regulatory use. So the quality criteria needs to encompass the entire process in order to generate real-world evidence from the data sources and processing to defining appropriate use cases. And the clinical relevance should use the analytical approach, and the limitations, of course, enable appropriate interpretation and the use of these real-world evidence data. The differences between clinical trials and real-world studies, usually in randomized clinical trials, the trial is designed to show the causability. The patients are randomly assigned to treatment or to comparator, and the data is derived from prescribed pre-specified protocol-defined inclusion and exclusion criteria, and it is highly monitored and controlled in the environment. In the real-world studies, we can only evaluate the association because we are not unable to determine the causability. Patients, of course, are not randomized. Data are observational in routine clinical practice setting, and outcomes are based only on the clinical judgment of the physicians, with the variability in patient care and adherence. Routine clinical practice, it is a routine clinical practice, and it is used on a broad population, patient population. So let's look into the first real-world evidence. I will show to you 3 real-world evidence for palbociclib, 2 looking into the response rates as a progression-free survival, and the third one will look into the overall survival. So in the first real-world evidence, it's called IRIS, Retrospective Chart Review. The objective was to study the demographics and to see in real-world setting what is the behavior of patients receiving palbociclib. It was a retrospective record review of 650 patients by 65 physicians. The data was published in 2018. Those patients were hormonal receptor positive, HER2 negative metastatic breast cancer, They were either treated by palbociclib plus aromatase inhibitor, 360 patients, or palbociclib and fulvestrant, 292 patients. It was a network of a nationwide American US physicians, and the recruiters recruited selected physicians who met both eligibility criteria and were willing to participate. And this was done over a period of 3 months from July till October 2017. The patient characteristics were, you know, the median age 65. There were different ethnicity. There were either recurrent from earlier stages patients or de novo patients. But here you see the difference in the palbociclib and fulvestrant, you know, recurrent from earlier stages was the majority of the cases. The stages were either loco-regional in a small percentage of the patients, or metastatic in the big majority of the patients. You know, up to ECOG 3 performance status, 3 patients were included, and metastases were either visceral or non-visceral. So when you look into what was associated with palbociclib, you had in the majority of the cases letrozole, but also anastrozole and exemestane were used. And if you look in the line of treatment, first line treatment was in the majority of the cases for palbociclib, and the second line treatment, the majority was with fulvestrant. If you see the doses, as you see, 78% of the patients had dose reductions, and the majority of the dose reductions were the dose adjustments. The dose adjustments were in 19% of the cases for palbociclib, and in 14% of the cases for palbociclib plus fulvestrant. So only 20% to 30% of the patients had dose reduction of the classical dose of 125 milligram of palbociclib, only 20 to 25% of the cases. If you see the progression-free survival, so the patients who were, you know, on palbociclib and aromatase inhibitor at 24 months, 64.3% of the patients were still progression-free. At 2 years, 64.3% of the patients were still progression-free, and this was, you know, a very, very high result comparable to the classical results that we are expecting. And the patients who received palbociclib plus fulvestrant, more than 75% of the patients remained progression-free after 1 year, which is compatible of what we expect of these patients. If you look into the subgroup of patients, you know, they were stratified according to age, performance status, and most importantly, visceral disease. So as you see, half of the patients had visceral metastasis, and half of the patients didn't have visceral metastasis. If we look into the subgroup of the key clinical findings, the progression-free rates, if you go to less than 65 of age, more than 65 of age, you had a very nice, you know, progression-free survival for both less than 65 and more than 65. If you look into the ECOG status, of course, the ECOG 1 had the best survival, but look at ECOG 2 and plus, 53.7% of the patients were, you know, surviving at 12, progression-free survival at 12 months, and 35% of the patients at 24 months. Visceral status versus non-visceral status, as you see, you know, at 12 months, progression-free survival was equal. At 24 months, the non-visceral were better as expected, 80% progression-free survival for the non-visceral versus 50% for the visceral. If we go to the survival rate, and this is very important, at 12 months and at 24 months, let's go directly to the 24 months, 80, 80, 85 and 95% less than 65 years and 85 more than 65 years. ECOG status also an impressive 25 at 24 years, and for visceral status also an impressive non-visceral status of 90% and visceral at 87%. So if we go to the palbociclib and fulvestrant, here we have a little bit more non-visceral status and also a little bit more than 65 years of age. Also, I will go rapidly on that. Progression-free survival at 12 months, less than 65, more than 65, nearly the same. ECOG 0, 84.6, impressive. Visceral status is the same, visceral versus non-visceral. If we go into the survival rate at 12 months, as you see, less than 65, more than 65, nearly the same. ECOG 0, 97.6% at 12 months, and visceral status versus non-visceral status, slightly non-visceral status better than visceral status. So as we go into the limitations, of course, we didn't have a control arm. Of course, the clinical events could not be adjusted. Of course, all adverse reactions were not captured in this study. Data were only collected from physicians who were willing to participate, but the data collection process was validated. Data are specific to this sample, and the subgroup analysis are only exploratory. If you go to the summary, so outgoing studies are required to deliver mature clinical outcome data beyond 12 and 24 months in the real-world study setting. The frequency of palbociclib dose reduction was lower in both patients group compared to the Paloma randomized controlled trial, as you saw, between 20 to 25%. This may be due to non-observed bias where physicians select specific patients to start on a lower dose rather than starting all patients at 125 milligram per day. So this was really a very supportive collection of data supporting the use of the combination. In the Flatiron other real-world studies, it was electronic health record database study. I will go very rapidly on that. It was presented during late ESMO 2019. Palbociclib plus an aromatase inhibitor as a first-line therapy for metastatic breast cancer in US clinical practice. It was a retrospective evaluation of electronic record. It was 813 patients, and you know the outcomes were similar to the previous outcomes that I presented to you. It was the first-line patients aromatase inhibitor given with palbociclib. The median age was 65, and you know 94% of the patients were treated in the community. This is the characteristic of the patients, 813 patients. You know, visceral versus non-visceral, no visceral slightly higher than visceral. We had also brain disease, number of metastatic sites going from 1 to more than 4. Patient, this is the real-world progression-free survival. As you see, up to 48 months, we have 8 to 88 months, you have nearly 30 plus progression-free survival, and the median progression-free survival was 20 months. If you go in the age of the patient, you see that even the patients who were more than 74 years, the green curves, had a very nice progression-free survival, even a little bit better than the others. If you go to the response, to the responses, you had, you know, palbociclib in the patients were either it was, you know, 60% of the patient had a best overall response of complete plus partial response, which makes it you know, for the total of the population, very high. And if we go to the summary, the median, progression-free survival for this real-world experience on 800 and more patients was 20 months. The best overall response also was 60% in the first line. Don't forget that it was a heterogeneous overall heterogeneous population. Of course, the same limitations that I previously said. It is a retrospective electronic, health record database. It was reviewed. Some things were also missing, and there were a few things which were missing in the review. Tumor assessment did not all the time follow the RECIST. Therefore, these data are limited by the physician's interpretation and the documentation of the response. Findings from patients included may not be generalized to other patients' population, but also it is, it is idea generation and hypothesis generation. And my last overall, real-world data clinical practice will go on the overall survival for first-line palbo plus letrozole versus letrozole alone in hormone receptor positive HER2 negative metastatic breast cancer, also in AUS real world. Please note the inclusion, the exclusion, and how all this was done. Patients retrospective. It is a retrospective analysis of electronic health records using a pre-identified patient data from a database where patients were reviewed either because they received only the letrozole, 658 patients, or because they received palbociclib and letrozole, 772 patients. The inclusion criteria were metastatic breast cancer, potential follow-up than more than 3 months, and patients were included between February 3, 2015 and February 2019. The exclusions were the evidence of prior treatment with CDK4/6 inhibitors. This needed to be as a first line, and treatment with CDK4 as part of a clinical trial also were excluded. So really, it was a real-world, clinical practice. The major outcome of interest was the progression-free survival, and the second outcome of interest was overall survival, and also the duration of the follow-up, and very, very, very dedicated statistical analysis were performed in this. If you look into the characteristics of the patients, you will see that the characteristics of the patients were adjusted because it was part of the process to adjust also the clinical characteristics of the patients in order to have interpretable data. So the characteristics was adjusted. And if you look into the results after the adjustments between palbociclib, letrozole, and letrozole alone, you will see that these were really adjusted between the two of them. Let's go to the result. This is the adjusted. Please look into the right. This is the adjusted, and of course you can look into the left of the slide. But we are really interested in the adjusted, because the categories of the patients were identical, and the characteristics of the patients were really identical. If you look into the progression-free survival of the patients who were on palbociclib plus letrozole, 20 months. If you look to the patients who were on letrozole alone, you have 11.9 months. If you look into the overall survival, so the adjusted figures are to the right. So after the adjustment, the overall survival median was 43.1 months. The median overall survival was 43.1 months. In the letrozole alone group, had not reached in the palbociclib plus letrozole alone group. And if you go to up to 48 months, you will see that the median overall survival is 50% maybe for the group of letrozole alone, and more than 60% survival rate at 4 years for the group who received letrozole plus palbociclib. Very interesting data. Very, very interesting data. If you look to the overall survival by subgroups, you don't need to be a statistician. The red dots are favoring the palbociclib letrozole. The blue dots are favoring the letrozole alone. And here you see, I don't know why in the race or unknown, you know, it's favoring a little bit the race unknown is favoring letrozole. But if you look all the, you know, subcategories, the stage, the number of metastatic site, bone only, not boy only, brain metastasis, not brain metastasis, visceral, no visceral, all the dots are favoring, you know, the use of the combination of palbociclib plus letrozole. If you look into the subsequent second-line anti-cancer treatments, you will see that, you know, in the palbociclib and letrozole arm, nearly 50% of the patients received a subsequent line of treatment. In the letrozole alone, more patients, 66.6% of the patients received a subsequent treatment. And here you see that, you know, patient can receive either a second CDK4/6 chemotherapy, another endocrine therapy alone, or other anti-cancer treatment. So the majority of the patients who were on letrozole alone received a subsequent second line of treatment. So also, you know, including CDK4 inhibitors. So even if there were as a crossover or cross use of the CDK4 inhibitor, you know, we have these results. So in summary, in the real world setting, the first line, palbociclib plus letrozole, definitively is more effective than letrozole alone, even in heterogeneous population and among various patient subgroups. After also, you know, stratification and adjustment. The adjustment real world progression-free survival hazard ratio was 0.58 and was 0.54 for the progression-free survival and 0.58 for the overall survival. These data complement, of course, the superior clinical efficacy observed with CDK4/6 inhibitor in combination with aromatase inhibitors already seen in randomized clinical trials. Although the median overall survival was reached in the letrozole arm alone and was not reached in the combination, significant censoring in the overall survival analysis highlights the need for subsequent evaluation with longer follow-up. Of course, there is the limitations that I have previously said. This is retrospective. Some erroneous data may be, you know, not present. Disease progression was assessed on the physicians, you know, evaluation. Patient treatments were not randomized. Treatments were not randomized related to the treatment selection for individual patients is possible. You know, comorbid, you know, a condition could have not been captured because it was not a clinical trial. And findings from patients included in this database may not be generalized to other patients' population, but still, this is very interesting, you know. Still, this is a very interesting, you know, survival data. As you know, survival data, you know, is very important, and it has been, you know, generalized by this real-world clinical practices, and it was, as I told you, presented during the ESMO, and also it was also presented during the San Antonio 2019. So I hope that I wasn't very long. What is the take-home messages? The addition of CDK inhibitors appears to confer similar progression-free survival benefit for all subset of patients in the metastatic and locally advanced settings. The benefit is seen in the first-line setting with aromatase inhibitor and second-line setting with fulvestrant. In the real-world data, the IRIS and the HER and the real world data also of the overall survival. So in the iris and the HER, the progression-free survival was consistent and similar to what we have seen in earlier studies, randomized trial, and even the latest result from the real world data which were presented in ESMO and the San Antonio also confer overall survival superiority of the combination over the use of letrozole alone. Thank you very much for your thank you very much for your attention. Thank you.
Thank you. Thank you, Dr. Marwan, for stick to the time. We are happy really to have this excellent lecture now. It's my pleasure. Questions and answers will be at the end to the session. Now I will present my friend Dr. Fadi Farhat, who is the president of the CRG, and he is the head of the Hemato-Oncology Department of Hammoud Hospital University. Please, Dr. Fadi. Please, Dr. Fadi. Dr. Fadi, are you hearing Dr. Fadi?
Yes, hi, I'm hearing you.
Now we hear you. Now we hear you.
Yes, hello, but I cannot reach the screen in order to join you. Okay, can you see my screen? Hello, I will share screen. Okay, please, Carla, can you give me the possibility to share my screen? Voila, it's okay. Sami, do you see the screen now?
Yes.
Yes. Hi. Yes. So, thank you, Dr. Sami. Thank you for all the attendees, the panelists, and the speakers. Thank you, Dr. Naji, Saghir, Dr. Alaa, Kandil, Fadi Farhat will join us. Thank you, Dr. Tahseen Alrubai from Iraq, and Dr. Marwan Ghosn. My task is to make some reminder about the growing use of molecular pathology in early breast cancer. Just to say that in breast cancer, traditionally, the prognostic factor that we are using are tumor size, the age, and the tumor grade, knowing that immunohistochemistry is not always the best way to do that. And there has been a review of more than 330 studies, and the authors reported that there was 20% of IHC determination incorrect, not valid. So which means there's a discrepancy, and we are soon publishing a similar data on on Lebanese population, where we will show that there was a big discrepancy in the HER2 positivity, showing that the analyses are not always easy to do. So the authors said that these false positive or negative are due to the pre-analytical factors, the threshold for positivity, and criteria. But that is very important because we know very well that some patients can avoid the chemotherapy if the need of it is not really confirmed. So those who are HER2 negative might skip the chemotherapy in some cases and go only to hormonal therapy. And while, as I said, the traditional tools to decide for that are the age, we used to say that it's for young patients, the grade or ERPR, tumor size. Now we know that there is something else helping us. It's the evaluation of the gene signature. So the assay, what we call gene signature assay, will lead us or will give us a hint for hormonal therapy to be as a definitive treatment, or hormonal therapy plus chemotherapy. But this should be taken in good decision, and finally the clinical decision is the most relevant. Now I want to tell you that the first which talked about the recurrence score was Oncotype DX, and they based their decision using key genes linked to critical molecular pathways like estrogen, as you can see, proliferation for estrogen, ER, BCL2, proliferation Ki67, and others like cyclin B1, MIBL, for HER2 invasion or others. So for each pathway, they took some critical genes that they thought are important. And they confirmed that yes, there is a difference. There's a difference that the 10-year probability of distant recurrence for those patients in yellow are really low compared to those who has a high score. So it means that for negative breast cancer disease in early stages, the recurrence score could predict the recurrence risk. And then after, they also, it was also proven on the NSABP trial where the patients received chemo with hormone or hormone alone. They could show that the 10-year rate of recurrence for those with low recurrence risk was really better. So there was better survival compared to the high risk, showing again that their method was valid, and they could show that the benefit of chemotherapy is greater when we give it for the high risk. As you see the difference between the high risk without chemotherapy in red and the high risk with chemotherapy, this curve. So they could prove that there is almost 30% benefit from chemotherapy plus hormone therapy compared to hormonal therapy alone. So here it's well shown that those who received chemotherapy and hormonal therapy did a lot better than those who did hormonal therapy alone. So the Oncotype DX in this trial showed that it's good. So what is the reason behind that? The reason is that even in small tumors, but because usually we decide about small tumors, even in small tumors, you can see that in red, there is patients with high recurrence score when we do the assay. And even in the biggest tumor, you can find some cases with low recurrence rate. So again, I repeat, being small is not enough for a tumor to say that there is no risk for relapse, because if you do the assay, you can find that there are high risk. And also, even a younger patient having low recurrence score, patients less than 40, they might have also no need, they might skip chemotherapy, because for the patient less than 40 as age, you can see that there is 44% that will not need chemotherapy because it's low recurrence score in this case, while for some older patient, there's still a need for chemotherapy. In red, it shows that there is need for chemotherapy because it's high risk score, and the green is low risk score. So again, even for some young patient where we consider that chemotherapy is a must, 44% will not need chemotherapy because they have low recurrence score. And a significant proportion of high-grade tumors have low recurrence score. So now we talked about the age, we talked about the size, and even about the grade, which is a criteria. Usually it was a criteria to use a treatment. You can see that poor prognostic, high grade can have 36% of case possibility of low risk. So they do not need at all the chemotherapy. And even in case, you can see here that also the poor also might have 19% by the central review. So again, it shows that following the high grade only as a factor will not be enough in such cases. And in 2015, there was the Taylor-X trial where also they, on 900 sites in 6 countries, they took a huge number of patients, 100,000, and they tried to analyze also the same issue and trying to understand if there is an importance for the score. And as you can see, they tried here to split the score between 11 to 25 as intermediate, less than 11, less than the 11, it was low, and higher than 25 is what it was high. They tried to understand if the recurrence is slow in the patients having less than 11 will recur, and they showed that at 5 years, the recurrence was only 1%. So again, if you do an oncotype analysis for a patient with node-negative early breast cancer, and it shows a low recurrence score, it means that at 5 years, there's only 1% risk to relapse, which is amazing, which is confirmed that there is no need for chemotherapy because 1% is so low. And they confirmed that the recurrence score results less than 80 may be safely spared adjuvant chemotherapy by the 5-year disease-free survival relapse-free index. It was shown and evident. So for those who are less than 11%, 10 and less, you can skip the chemotherapy because the risk of relapse is less than 1%. And they could show that we have things that we have said earlier, that neither age, neither size, nor grade impacted the 5-year distant recurrence risk or overall survival. So again, it's not only about recurrence risk, but also about survival. Look how the survival is maintained. Okay. So these are the conclusions that I already said. But I talked about the oncotype. It's not the only one. We have mama print, we have prosigna, we have some others like on the print, etc. So now, what are the challenges with these methods? First of all, what's the importance of turnaround time? Because we know that these patients will be anxious. I think there will be no problem because all these have almost the same delay to give the results, and usually if you do it immediately after is there any importance of subtyping to decide on systemic treatment? Because we know well that the oncotype will not approach the subtype of the disease, while some others might do that, like the prosigna, where it will give us which type of which subtype is it, luminal A or luminal B, which can impact our decision in some cases. So it will be like a centralized review, a second review of the subtype. Also a challenge, can this method, can this assay help us in late recurrence date? Because there's also a risk of recurrence scores evaluated in the PAM50, which is the prosigna. It's evaluated, and it shows that the data at 10 years is maintained, while the data with others like oncotype is only at 5 years. So will this impact our decision? Also, the main problem, we are talking about many essays on the predict, mama print, oncotype, and prosigna, and others. Are they the same? Are they different? There has been some publication showing that oncotype and prosigna, for example, I will not go through all the data, showing that the test is not the same. And I can tell you that is not the same because the number of genes used for this assay is different, and the number is different, and the type is different. And here you can see that if you use the prosigna risk group, you can find that there's a concordance in this part where it is low in both, while it's not the same because it's intermediate with oncotype, while it's low with prosigna, it's high with oncotype, and it's low with prosigna. On the other hand, those who are classified as high risk by prosigna, they are high risk, are really low risk in oncotype. So for the first time, I think here, should we do 2 tests to be sure that there is no need for chemotherapy? specifically in young. For sure, we cannot do that. No insurance will accept it, and logically, it's not accepted. But it's just to show that to show that there is a discrepancy in these tests, and even in luminal A, luminal B evaluation, there is a difference between the oncotype testing or luminal or the Prosigna testing. So the difference is even in subtypes, as you can see. So also a challenge, can we do the test in node negative? Because if the patient is really insisting, in some case, some doctors will go to use it. And because there is a trial showing that the recurrence score may be different when the recurrence score may be different and will impact the need of chemotherapy. If the recurrence score is less than 18 on the SWOG trial, for example, even if the nodes are positive, look, there is no big difference between the two curves, while there is a big difference when the recurrence score is high, showing that it might work in a node positive. And here I will wait the panelists to discuss with other issues this topic, because N positive for us seems a real challenge. And what about the recent publication in the recently ASCO? The MIND Act was also evaluated in a long-term results at 8 years, in long-term follow-up at 8 years, and they tried to see if there is difference between the clinical high rate and genomical low rate. And the mama print, just to remember, it's 70 genes, so totally different from oncotype, which is 21, or Prosigna, which 50. So as you can see, there was only a 2.6% difference in the chemo versus no chemo. So is it enough to skip chemo? I don't know. So just I am putting all these to show you that there is a lot of essays, and there is still a debate which one is good, and you will never find a KOL or a colleague who will tell you that I'm more confident with this one, not the others. Every essay has its method. So it's the best way is to go to the guidelines, and I presume that in this case the best one, in my opinion, is the ASCO showing in its 2017 paper in the paper of use of biomarkers to guide decision on adjuvant systemic therapy for early breast cancer, that the mama print, in their opinion, might be used and should be used in ER/PR positive, HER2 negative, node negative with high clinical risk, as per MIND Act trial, and ER/PR positive, HER2 negative, node positive, high clinical risk. It was the recommendation twice done, but in all other cases it was not recommended. I've put also only in red where it's recommended. For oncotype also, they showed that for ER/PR positive, HER2 negative, node negative breast cancer, you might use the 21 gene recurrence score, the oncotype, to guide decision for adjuvant, but not in node positive or triple negative cases. And the EndoPredict, for example, was also in ER/PR positive, HER2 negative, node negative breast cancer, accepted as a method. So as you can see, it's limited to N negative for the moment. And really, these are, as resumes, these are different essays with different genes in number and in total in different genes. And you cannot talk about a preference, but with the Taylor-X, we have a long follow-up. With Taylor-X, you can say that less than 11, you are really sure that you do not need chemotherapy, while in Prosigna, for example, you have a recurrence, a risk of recurrence, and the subtype, and you have a longer follow-up. And for mama print, really, it's interesting to use in high-risk patients. And personally, I use, if I have not positive, the Mind Act data. And with that, I thank you very much for all the attendees and my colleagues, speakers and panelists, and Dr. Khatib. And I give the floor for Dr. Khatib. Thank you very much.
Thank you, Fadi, again. And now I will introduce our excellent panelist who's going to talk and to discuss about the lecture of Dr. Ghosn and Farhat. First one is Professor Alaa Kandil. Professor Alaa Kandil, as you all know, he is the chairman of oncology at the Faculty of Medicine, Alexandria University in Egypt. And Professor Fadi Farhat, who is the chief of the Hematology Oncology Service, Beirut Medical Center in Lebanon, and our colleague Professor Tahseen Alrubai from Al-Amal National Hospital in Iraq. Please, the floor is yours.
Dr. Fadi Farhat is here or not yet?
We can start. I don't know if he is in with us, but we can start. Dr. Alaa, if you have any comment.
Sure. Yeah, actually, I'd like to thank first the organizer for giving me this opportunity, and I'd like to thank the two speakers for their elegant presentations, Professor Ghosn and Professor Fadi Farhat. Just to enlighten, actually, that I guess for Dr. Ghosn, nowadays we know exactly the role of CD46 inhibitors in the management of patients with metastatic breast cancer, but I'd like to ask Dr. Marwan, Ghosn, and all other experts, do you feel more comfortable using one of the CD46 inhibitors as compared to others, or they're all the same? Would be it like age, like disease characteristics, like comorbidities, heart conditions? What do you feel, Dr. Ghosn, about that?
Yani it is the 1 billion, not the 1 million, the $1 billion question that everybody is asking. Which one of those, is it the class effect? Are they all the same? Usually the most important point that I look at is side effects and comorbidity profile of the patient. So when I have a patient, I can anticipate what kind of side effects I will have from one drug to another drug. So, and I will usually, most probably, will use the drug according to this profile of the patient. One other of the record thing which makes me choose one drug over another is also the availability of the drugs. You know, we are in a very difficult and tough pharmacoeconomic situation, and of course we need to support also our patients. So what is available in the third-party payers, in the Ministry of Public Health, in the Army, we are using those drugs and, you know, adjusting the side effects with our patients.
Okay, so we do agree, I guess, everybody, about the patient's characteristics, availability, and toxicity profile or comorbidities. We all agree on that. But like, for instance, would you reserve abemaciclib, or you prefer use abemaciclib in patients with brain metastasis, for instance, or it doesn't make any difference for you? Because we have data to suggest that abema is a little bit more superior in this area.
I agree with you on the two dates, the two things that you have on abema. I didn't want to go into details, but you know, of course, we have some data supporting the use of abema in brain metastasis, and also you have the other data which say that you can use abema as a monotherapy after progression of patients on the combination. So you know, sequencing was also important in us. We don't have so many data till today, but I think in the future we will have more and more emerging data on the use of these drugs that will help us maybe also sequence the drug or change the association, you know, also change the CDK4 inhibitor and change the association from aromatase inhibitor to fulvestrant, etc. We need more data in order to know how to sequence these drugs.
Well, I can't agree more, actually. One more question, and for the CD4/6 inhibitors, actually, do you see actually that patients who develop resistance or disease progression after the use of CD4/6 inhibitor are candidates for what? Change the hormonal companion, change the CD4/6 inhibitor, go to a PI3K inhibitor? I know that Dr. Fadi Farhat also is one of the heroes in this area. So I'd like to hear from you both, Dr. Naji. What do you think about disease progression on CD4/6 inhibitors, please?
In fact, last week I presented during the Lebanese Society of Medical Oncology meeting that we had the topic of what to do after CDK4, CDK6 inhibitor. And the conclusion of the topic was, of course, you need to look at the PI3K, inhibitors and to see if you can use this drug. The second, we don't have really nice data of mTOR inhibitor association with the use of mTOR inhibitor as a second line after those drugs. There are some preliminary data saying that there is some, acceptable and very nice responses, but everybody fears the toxicity of the mTOR inhibitors. We have some new drugs coming also, and also there is the use of the AUBMC. We didn't use the abemaciclib as a first line, and we don't really know. I would like to hear the opinion of our friend Dr. Fadi Farhat and also of our friend Dr. Naji Saghir, which I see have joined us also, on what to do. I don't think that there is the right answer. Maybe one right answer, that the patients who have the PI3K mutation needs to take a PI3K inhibitor. But for the rest of the patient, what is the right answer?
I can't agree more, but I still would like to hear from Dr. Fadi, Dr. Naji, and Dr. Tahseen. What do you do when you have this situation, please?
Should we start with Dr. Naji? He's our senior. Dr. Naji, can you start? Please unmute your phone, your micro. Yes. What do you think, Dr. Naji?
Okay, thank you, and hi everybody. It's nice to see you all on this session, and thank you for organizing this.
Yes.
Alaa, this is Alaa, your question on everybody's mind all the time. But definitely, one thing I would like to say: there is no need to compare the three agents. We all treat them as a class of drugs. They are a class of drugs, CDK4/6 inhibitors. Now, there are some differences in the toxicity that one takes into consideration when you want to choose which one or the other, in terms of also clinical trials. Like ribociclib was the one was tested in premenopausal women. One might have a tendency to use it, but however, you can use the other three. Survival advantage was seen in some drugs, while not as marked with the others, because of the characteristics of the patients that were also included in those trials. So I think overall, we still treat them as a class of drugs, and major determinant remains the cost, and the accessibility that the patient can have. If a patient recurs after CDK4/6 inhibitor, well then, as Fadi said, you all said, alpelisib is a choice, and that was presented at ASCO 2 weeks ago. Oprugo presented the data that yes, it is effective after CDK4/6 inhibitor. Now, abemaciclib can be considered as a single agent for refractory patients, as well as we have the Monarch 1, a study, and it was approved for that. We're gonna keep debating this, I think, but I think, as was said earlier, accessibility is one of the most important factors for this.
Okay, thank you, Dr. Naji. Please allow me. to take questions.
Dr. Alaa, thank you very much. And thank you very much for the organizers as well as for the wonderful speakers, our friends. Hello.
Dr. Tahseen, would you like to give an opinion on these issues?
I have actually two important questions to Dr. Marwan. Now, I totally agree with you about the progression-free survival advantage and as well as the overall survival advantage, which is actually not statistically significant, but clinically actually it's meaningful. If you go back to the late 1970s, 80s, 90s, we were doing absolutely nothing to those patients, and the survival care were actually plateauing to zero. Now, what's interesting in what presented by Dr. Marwan is in the IRIS study and in the Flatiron data that significant proportion, actually a good proportion of patients, around 14% in the Flatiron data and the 20% of patients in the IRIS data were having stage 3 disease. So my question to Dr. Marwan is, how do you think that we should deal with those patients with the stage 3 disease and starting them on CDK4/6 inhibitors plus aromatase inhibitor, taking in consideration the financial toxicity as well of this particular drug, or keeping those important drugs when the patient is going into the metastatic setting?
Thank you, Dr. Tahseen, for your comments. As usual, very pertinent and going straight to the point. The locoregional disease or locally advanced metastatic, locally advanced non-metastatic breast cancer, we know that these patients will behave like metastatic disease very rapidly, and they will develop metastasis very rapidly. I will reply in saying two things. Currently, there are trials on the use of CDK4 inhibitor in the neoadjuvant setting. So if we are doing trials to use them in the neoadjuvant setting and trying to see what is the response of these patients, and in these neoadjuvant settings, there are a category of patients who are locally advanced, not only neoadjuvant small tumor or so, but there we have some patients who are locally advanced. And we have seen in preliminary presentations in ASCO, in ESMO, we have seen in preliminary presentation very nice responses, including pathological complete response in these patients. So the concept of the response to these drugs is here. We need the trials, of course, in order to implement the use of these drugs in a general way for this subcategory of the patients. But here I take you to a second concept. When I was a medical student and a very, very, very young fellow, and this was tens of years ago, I will not tell you how many years, with my beloved professor who died a few years ago, Professor Naji Talib. Some of you knows Professor Naji Talib, Allah yarhamu. He used to tell me that in sequencing, keep your best drugs, don't use your best drugs at the beginning. And he liked very much to sequence and keep something for the next. But you know that this theory has been challenged a lot of time. And nowadays, when you first treat a patient, usually, unless you are in a palliative situation where you know that you will not really impact on the survival of your patient, if you think that you can impact on the survival of your patient and not only on the progression-free survival, a lot of us, at least I am from those who will use his best drugs at the beginning. I will use my best drugs at the beginning, aiming to get a very nice response, aiming to get the best of progression-free survival, aiming to get an impact on the overall surviving, telling myself that if I get the best at the beginning, maybe I will have another best in the future, and my patients will still be around us in order to have it. But this is really how I feel about using this drug. But of course, you are right. The trials with this, to see what is the best sequence in the use of the drugs is very important. The financial side effects and burden of these drugs, this is another story. I will not go into it because it will take us hours to discuss, and Dr. Sami Khatib will not be very happy for that because we know we will go out of the time. So, but I think, of course, it's very important, the financial side effects of these drugs.
Right.
Thank you.
My second question, please, is that I totally agree with what was mentioned by Professor Naji Saghir, that this is a class drug, and all the side effects, almost all the side effects are class effects with some difference, and all of them were actually manageable. Now, my question is about the macrocytic anemia. Now, we know that a good percentage of patients who were on CDK4/6 inhibitors presented to you with a hemoglobin of 7, 7.5, and so on. And if you go to the blood film, it will be shown as macrocytosis. And all of us are actually managing those patients with folic acid and B12, etc. Now, in your clinical practice, what percentage of patients went into anemia?
To whom is
Saghir, the question is for you.
For Dr. Naji.
What is the question?
The question, Naji, is that we can observe some microcytic anemia in the use of CDK, macrocytic anemia and the use of CDK inhibitors. Yes.
Yes.
It might be because they inhibit. You might get it because when a mute or an unmute سامعني.
سامعينك ناجي, we hear you.
I have not noticed particular attention of this clinically nor in trials, but we can get that because you have a cell cycle effect and you may get some macrocytosis, but I don't recall any recommendations, and I certainly would not use folic acid nor B12 supplementation. You don't want to affect the cell cycle arrest effect that those drugs have on cancer cells. I don't know if I answered your question.
Thank you, panelists. I think it's very excellent discussion that we are having. We'll keep more discussion in the next round after the lecture of Dr. Naji Saghir. Dr. Naji Saghir, as all of you know, Dr. Naji, he is professor and head of the Division of Hematology Oncology, director of the Breast Cancer Center of Excellence at the Naef Basile Cancer in the AUB. Please, Dr. Naji, if you would like to start, just to save time, and please, if we stick to the time, to have all participants. We have an excellent number of participants from all over the world, mainly from MENA area.
I have to share my screen. 1 second. Do you want to continue? What is this?
Yeah, just to tell the audience, if you allow, Chairman, dear Chairman, that the questions will be answered at the end. I saw that Dr. Kakil also had some question. There's some interesting question. Please, can you take it? Because the most important is the educational aspect of this course. Thank you.
At the same time, all the speakers, please check the questions, and if you have the answer of any of these questions, just let us know.
Shall I start?
Yes, please.
I'm trying to share my screen. Is it shared?
Yes.
Yes?
Yes, Naji, we can see it.
Okay. Okay, thank you very much, Fadi, for this invitation. Happy to see everybody. on WebEx, online, virtual, but hopefully we'll see each other soon. My task is to talk about في شنو الصور من هون اللي مغطين الشاشة عندي. We're going to talk about key updates in the management of metastatic breast cancer. This is the title of the module. بس هيدي كيف شيل الصور هيدي يا شيخ؟ okay, I got it. Okay. Now my task is to talk to you about updates in HER2 positive metastatic breast cancer. This talk is sponsored by Roche, but they have nothing to do with the talk, but it is sponsored by Roche. So we have to put this disclaimer. Now these are my disclosures. Okay, now overall, in general, as you all know, breast cancer, #1 incidence and mortality in women worldwide. This is the GloboCan 2018. Now the metastatic breast cancer, that is our subject for today. In the US, only about 5 to 10% of the cases at presentation. In Europe, about 5 to 10%. In low middle income countries, goes up to 60% locally advanced and metastatic. In Lebanon, most of the data that we recently have, about 35% locally advanced plus metastatic, which is a change from what we had 20 years ago with all the awareness campaigns that we do. It really had made a difference. Now we are all afraid, and hopefully this will not last too long, this pandemic, the COVID-19 pandemic. A lot of people are staying home, they're not going to the doctors, they're not doing screening. So we may see an increase in locally advanced and metastatic breast cancer at presentation. Now, patients who have early breast cancer, well, up to 20 to 40% of them may do recur. So this is a very important subject. Now, hormone receptor positive represent up to 70% of the cases. HER2 positive, 20 to 25% of the cases. A large percentage of them is HER2 overexpressive that we call about 15%, and there is small percentage, 5+% hormone receptor negative, overexpressive. Now, the triple negative in about 15% of the cases. The HER2 positives are usually more aggressive. We have earlier occurrences. The hormone receptor positive may recur late. They are responsive to anti-HER2 therapy. Now, metastatic patients who do have metastatic HER2 positive breast cancer, up to 50% of them will develop brain metastasis. Metastatic breast cancer is generally not curable. However, we have had significant recent survival improvements with targeted therapies, especially with HER2 positive and to a limited extent with CDK4/6 inhibitors. This is a reminder, you all know 2+ equivocal, we need the FISH test, 3+ are considered positive. Those are the drugs. There are a lot of, maybe whoever is not talking can mute his or her computer.
To close the micro.
سامعين ضجة؟
Yeah, سامعينك بس I'm asking all the speakers to close the microphone.
Okay, thank you. We're going to talk about chemotherapy. We're going to talk about anti-HER2 therapy, the monoclonal antibodies, trastuzumab, pertuzumab, anti-HER2s, TKIs, kinase inhibitors. We have the lapatinib, daratinib, and the tucatinib, anti-HER2 drug conjugates, the TDM1 and the DXD, hormonal therapy, and other new agents. This is the landmark study by Dennis Slayman that showed that adding trastuzumab to chemotherapy improves survival in patients with metastatic disease. That was published back in 2001. We have new drugs on board. The trastuzumab anti-HER2 We have the HER1, 2, 3, and 4. We have a new drug that is the pertuzumab that inhibits the HER2 and the HER2-HER3 dimerization. That is important for the downstream signaling and cell proliferation. So escalating the treatment, adding pertuzumab to trastuzumab plus chemotherapy, did that produce a positive effect? Well, the Cleopatra trial, we have pertuzumab versus placebo randomization added to trastuzumab and docetaxel in both arms. Arm A, we have placebo and we have pertuzumab, and these patients were randomized and stratified according to geographic region and neoadjuvant adjuvant therapy. Those are the dosages that we are all familiar with. Now, at the final analysis in 2015, we have seen a significant improvement in the progression-free survival, 6 months improvement. More importantly, we have a 15+ month improvement in the overall survival. Pertuzumab, trastuzumab, docetaxel, 56 months and 40 months for the placebo arm with trastuzumab, docetaxel. So we have a significant improvement of the overall survival with a hazard ratio of 0.68. Now, this study was updated several times, and the latest update, which is the end of study, we have maintenance. The progression-free survival benefit was maintained after more than 8 years of follow-up. We have PFS 18.7 versus 12.4, and the overall survival at more than 8 years again was maintained. We have 57 months overall survival in the pertuzumab trastuzumab arm and 40 months in the trastuzumab arm along with docetaxel. So that established pertuzumab upfront therapy with chemotherapy for metastatic breast cancer. The study used it with docetaxel. We have the Peru study and other smaller studies that used it with paclitaxel, and we have other studies that added vinorelbine or other drugs. So we have a choice of drugs, or capecitabine. We have a choice of drugs that combine with trastuzumab, and we extrapolate adding pertuzumab. In the follow-up of the Cleopatra trial, we see that throughout all the years of follow-up, there was always a significant advantage for adding pertuzumab. The side effects were rather equivalent. There was good safety profile, but the cardiac safety profile was also similar, minimal differences, and there are people who were crossed over. So the safety-wise and efficacy was maintained. So the conclusion of the study was that we see a significant overall improvement. Investigator assessed, end of study assessment, also safety profile was very good. Long-term cardiac toxicity was maintained, no increased toxicity after longer follow-up. And the longest follow-up of patients for first-line treatment, HER2 positive, of course, this is seen in this Cleopatra trial. And this final end of study update confirmed that pertuzumab, trastuzumab with chemotherapy remains the standard of care for patients with HER2 positive disease. All the guidelines have it, the ABC 5 guidelines also, we have it, standard first-line therapy, previously untreated with anti-HER2 therapy, combination chemotherapy. See, we added just chemotherapy to give physicians a choice of using other drugs, plus trastuzumab, plus pertuzumab. Now, do we have other drugs? There are patients who recur. Not everybody is cured and have maintained complete response or survival, pertuzumab, trastuzumab, or trastuzumab alone initially. A lot of patients do recur. So we have the TDM1, the drug conjugate, the antibody with a linker and imtensin that is a chemotherapeutic agent. This drug, I like this slide, I always like to show it. You have internal, and it gets hooked on the HER2, it gets internalized and broken up by the lysosome, and the imtensin works on the microtubules polymerization, and you already have the anti-HER2 effect over here. So we have a double effect, imtensin and the HER2. We have now second line study, the Emilia trial, comparing TDM1 versus capecitabine and lapatinib. At the time, in the early 2000s, the standard of care was capecitabine plus lapatinib. So TDM1 in second line was compared to capecitabine lapatinib, and we have seen a significant improvement in the progression-free survival and also in the overall survival when we use TDM1 as second line. You can see it here also clearly. And there was also a reduced risk of death in patient in CNS metastasis, also as compared to lapatinib, capecitabine. But we have something newer that is more important, which is the tucatinib. Now the TDM1, therefore, increases PFS by 35%, increases overall survival by 31% when compared to lapatinib and capecitabine, and it has become the second line treatment for those patients. Now we have a safety trial, Camilla trial, that assessed also TDM1 safety. It was a single arm open label international study, safety phase 3B. Patients with advanced breast cancer with progression have had prior chemo and anti-HER2 or recurred within 6 months of completing adjuvant therapy. Primary objective was safety, and also they followed up these patients for 2 years, and we have seen that there was improvement in using a TDM1, and interestingly here it was used first line, second line, third line, fourth line, and the earlier TDM1 is used, the better results were seen. So this study, they had also a large percentage of patients with CNS metastasis, and we have seen using TDM1 improves their results. Now, so up to 2019, December 2019, we knew this overall HER2 overexpression and gene amplification occurs in 20% of the patient associated with aggressive disease, increased risk of recurrence. First line, initially, we had chemo, trastuzumab, second line, lapatinib, capecitabine, third line, chemo, trastuzumab beyond progression in the earlier days. Now, what we have, first line, chemo, pertuzumab, trastuzumab, second line, TDM1, in third line, if the patient has not had, TDM1, we use TDM1, and after lapatinib Xeloda, also TDM1 is okay, is acceptable. And we have used also trastuzumab beyond progression, changing the chemotherapeutic drugs. At that time, up to December 2019, there was really no clear consensus what to do in third line or beyond, until we have 2 new breakthrough drugs. Results were presented at San Antonio, tucatinib and trastuzumab deruxtecan, and later on they were approved, FDA approved, and we have the margetuximab monoclonal antibody that is still in trials. Initial results do not show significant benefit as we have seen with tucatinib and deruxtecan. Let me give you an update on the Destiny Breast 01 trial, trastuzumab with deruxtecan. This study was initially a dose finding, and it was an open label phase 2 study, and the settlement was that we have 184 patients that were given 5.4 milligrams kilogram of trastuzumab deruxtecan. The results were very encouraging. We had the trialists had 6% with complete response, 54% partial response, stable disease, and 36%. So almost everybody responded. We have a disease control rate of 97%. And the duration of response was 14 months, progression-free survival 16 months, and the time of response was 1.5 months. So based on this data, authors concluded that this is a very promising drug in patients who were heavily pretreated. And based on this phase 2 trial, they had an FDA approval. The important thing to remember is that this disease side effects, inflammatory, lung disease is a very common toxicity. I had a slide on the toxicity. Sorry, it seems to be missing. This infiltrative, inflammatory lung disease is important and can be severe. So patients should be monitored very carefully and intervention very prompt. Now we have at the ABC5, as you know, ABC5 was completed in November 2019. At that time, we knew that the data was going to be presented at San Antonio after 3 weeks of our meeting. So we kept that open. And in January, we circulated this statement, and almost everyone of the panel agreed trastuzumab deruxtecan shows important clinical activity in this phase 2 study in heavily pretreated patients, HER2 positive ABC, and it is a treatment option in this setting where approved. We remind you that pneumonitis, pulmonary toxicity can be fatal and requires active surveillance and proper management. Now, at the same time in December at San Antonio, we had the HER2 CLIMB study presented. It was a phase 3 randomized study. Patients had trastuzumab capecitabine and added to that tucatinib or placebo. Tucatinib is a tyrosine kinase inhibitor, oral drug given at a dose of 300 milligrams twice a day. The primary endpoint was progression-free survival. Secondary endpoints for the total population, overall survival. Also, they had a secondary important endpoint, PFS, in patients with brain metastasis. Okay, look what we have. This trial had 48% of patients in the tucatinib arm and 46 in the placebo arm, of course, in combination with trastuzumab capecitabine, that had brain metastasis. And a significant number of them were untreated as well, and 22% were untreated. 18% had progressive, disease also, and the stable were about 60%. That was a very important component of the study. We see that they had a large number, of course, overall response rate, 41% versus 23%. Complete response, 3% versus 1%. PR, 40% versus 22%. Stable disease, 46% versus 59% equivalent. So we had significant improvement with this. Side effect, these are the most common side effects. It was more observed with the tucatinib, diarrhea, PPE, and food syndrome, nausea, fatigue. Remember, you have capecitabine on board also. These side effects were manageable, little more with the tucatinib, but they were manageable. And this is a summary slide of the data that was presented by Ms. Murthy at San Antonio. We have, at 1 year, progression-free survival, 33% versus 12%. The Overall survival was significant. Overall survival, you see it, separation of the curve, 45% versus 27%. And for patients with brain metastasis, 25% versus 0%. Median, these are the median survival. There is a modest improvement, a few months, but definitely we see a risk of progression reduced by almost half, 46%. Risk of death reduced by 1/3, hazard ratio 0.66, and the risk of progression of death in patients with brain mets reduced by half. Very important results. And again, the ABC5 panel had this slide circulated in January after the results were known, and 98% of the panel agreed that dual blockade tucatinib trastuzumab with capecitabine is considered a treatment option in this setting. And very important, 2 weeks ago, we had this data presented by Nancy Lin looking at the patients with brain metastasis in the HER2CLIMB study. They had 291 patients with brain metastasis and 174 with active brain metastasis. Okay, now look at the progression, CNS progression-free survival, progression in the central nervous system, definitely very significant. Look at this for patients with active brain metastasis. I don't know if I went over time, but I'm almost finished. So hazard ratio is 0.36 and the p-value is less than 0.00001. So very important. We have the 1-year CNS progression-free survival, 35% in the tucatinib group, 0%, you know, all these patients usually progress. And the median CNS progression-free, 9.5 months versus 4.1 months. We all have seen patients with brain mets that progress rapidly, and this drug is certainly very promising. Look at the overall survival benefit in patients with active brain metastasis. You see the median overall 20 months versus 11 months, almost doubles. So conclusion of the trial is that it doubles the rate of disease in the central nervous, rate of response disease in the central nervous system, reduces the risk of progression or death. And this means really you have a delay in the progression in the brain as well as improvement in survival. So this regimen definitely now is, it already had about 3 weeks ago, it did get approval by the FDA as well. So now, as a conclusion, an update on what we had in December 2019. First line now is chemo plus pertuzumab. Second line, TDM1. Third line, as I mentioned, what we had, TDM1 is okay after lapatinib Xeloda, and TDM1 okay after lapatinib Xeloda, and trastuzumab beyond progression. Now we have 2 new drugs as third line, trastuzumab deruxtecan, and tucatinib plus trastuzumab plus capecitabine, and in the presence of brain metastasis, tucatinib had very significant activity. So we're really seeing very exciting developments in the treatment of HER2-positive metastatic breast cancer. And with that, I thank you for your attention.
Thank you, Dr. Naji, for the excellent lecture. Now we have 5 minutes for the panelists. Dr. Alaa, the floor is yours.
Yes, thank you very much, Professor Naji. Can you hear me?
Yes, yes.
Okay. I'd like first to get our dear attendees, if they have any questions, please, to our experts. Any questions?
We have many questions, but we will let it after this discussion. Dr.
Okay.
Fadi,
Dr. Fadi, So I'll have 2 points, one to discuss with Dr. Naji and the other with Dr. Fadi Farhat. Dr. Naji, now in view of the data that's already been presented last San Antonio, would you, in a patient who developed brain metastasis, a HER2 positive disease, after already receiving Herceptin and pertuzumab, go straight ahead to the tucatinib regimen or still try this patient's TDM1, and in case of progression, you go to tucatinib? What do you say?
Well, you know, we don't have data, of course, about this, but it definitely makes sense that tucatinib is going to be used in third line, you know, and even in second line, we don't have data, but I think it's going to be used. I think people will use it. If you have brain metastasis, I think definitely we would use it. We don't have data, we don't have now in second line, but it is in progress. You know, there are trials using it in second line.
Okay, because the data of tucatinib actually are very impressive, and actually it's even more or better than the data with TDM1 and brain metastasis. Do you agree to that?
Yes, absolutely.
Okay. Okay. So one last question to Dr. Fadi Farhat, please. Dr. Fadi, about the use of Oncotype DX, you mentioned that it's already been, according to the ASCO guidelines, to be used in patients with node-negative disease. However, and correct me if I'm mistaken, actually, I know of good breast experts still use it in node-positive disease, but only 1 to 3 lymph nodes. You agree to that?
Yes, I told you that there is data, but indeed, if you want to use it in high risk and lymph nodes positive is high risk, you have to think also about the MAMA print, which have data in the high risk category of patients. So it's not approved yet by ASCO, but you can use it, as I told during my presentation, for patients who really are against chemotherapy. You can give them this chance. If you explain also well, you have to explain them the risk that even if the risk is low, there is still a chance to relapse later on. Dr. Andil,
yes,
if you don't mind, I would
yes,
I'd like you to take the question of the audience. There is many interesting questions.
Yeah, but that's. But yes, I said that, but Dr. Sami said Dr. Fadi will answer them after the broadcast.
Okay, I'm sorry. Okay.
You can. Okay, no problem. Any one of you, because I don't know. I have some problem with the people who raised hand. So you can start, Dr. Alaa Kandil, with the questions.
There was 5 questions, but now I can see only one, and but it says actually from Dr. Suhaila Sayedi. She says, but we have not pertuzumab and TDM1. I don't know what does she mean.
They don't have pertuzumab TDM1. What to use? This is, I think, the question.
Okay.
This is the question for Dr. Naji.
Dr. Naji.
Okay, well, we use chemotherapy. I mean, usually this is what we did. If it is not available, you have the option of using chemotherapy. But we know, and it's been 20 years now, that we know that trastuzumab was a revolution in the treatment of breast cancer, and mainly primary breast cancer. I think it has become available almost everywhere. Trastuzumab, pertuzumab may not be available everywhere, but it would be a pity not to have trastuzumab available.
Okay.
No, they are saying that they don't have pertuzumab and TDM1. So the answer is also that if you don't have pertuzumab, you can work with trastuzumab alone. If there is no TDM1, there is also the other HER1, HER2 inhibitors that you can use. And also what we can suggest, Dr. Naji, if you don't have TDM1, you can re-challenge with trastuzumab, changing the chemotherapy backbone. Okay?
Sure.
Dr. Alaa, if you don't mind, I have all the questions I wrote. So from Hani Victor, he's asking if there's any comparison between aromatase inhibitor plus CDK versus aromatase inhibitors plus mTOR. This question is for Dr. Marwan, if he's here. Yeah. Okay. If not, does anybody want to answer? So is there any data concerning the comparison between
I am
CDK
here.
versus okay, it's for you, Marwan. CDK
Yes.
aromatase
Can you
inhibitor
repeat the
versus
question?
is there any study comparing aromatase inhibitor plus CDK inhibitors versus aromatase inhibitor plus mTOR?
I said during my presentation that there were no data on that I am aware of. There is no data comparing patients with CDK inhibitor plus aromatase inhibitor versus aromatase inhibitors plus mTOR inhibitor. And also we are still lacking of data of what happens to the patients who are receiving mTOR inhibitors plus any hormonal treatment after progressing on CDK inhibitors. So we are lacking the two of that. I think for the first, we'll never have a comparison. For the second, I think that we will have very soon some data on that.
If I may add something here, yani, initially we used, mTOR inhibitors. And once we had CDK4/6 inhibitors, the toxicity is so different. The tolerance is so much better with CDK4/6 inhibitors that definitely, as Marwan said, we will never look for a comparison between the two. We can use them in sequencing. Yes, this is approved, We can sequence failure on CDK4/6 inhibitor. You can use mTOR inhibitor, failure mTOR inhibitor. You can use CDK4/6 inhibitor. Although nowadays, if you have a PIK3CA mutation, if you can get alpelisib, it would be much better after CDK4/6 inhibitor or others.
If you may allow, also I will add quickly that the difference in the outcome is in
راحت الشاشة ما بعرف بعدك عم تحكي
دكتور فادي
You are frozen.
We are not hearing Dr.
Farraz.
Hello,
he's back.
hello.
He's back.
Farraz,
He's back. He is back.
Yeah, he's back. He's back.
He is back.
Resuscitated.
Thank you very much. So I was simply saying that the tolerability is very important, but also the better outcome, because the PFS and the OS benefit will oblige us to use it in first line. So thank you. I will go to the second question because also I have it. The second question is from Dr. Kakil. Does the menopausal status affect choosing the CDK4/6 inhibitor? What do you think? It's also a tricky question because there is data, the Mona Lisa 7, but Dr. Marwan, since the question is addressed to you first, please, can you comment?
Dr. Saghir said a comment at the beginning of his presentation that nowadays we are using CDK inhibitors as a class effect. So I think, of course, we have only the data of the Mona Lisa trial. We are waiting for the data of the other trials, but I think that we can use all of them in premenopausal. But the data is for ribociclib. Maybe it gives a certain push for ribociclib to be used in premenopausal, although I think that we can use all the drugs.
I agree. I think the class of drugs, we agree. And we may be biased because we were part of the Mona Lisa 7, yes, myself and Marwan and Fadi. And we have an overall survival benefit, but the three drugs are similar. But at the end, I think, yes, we may choose it. I may be biased to use it, but I agree. This is a class of drugs and all of them can be used. Although, had the magnitude of clinical benefit scale with ESMO, gave a higher mark for ribociclib because of the overall survival, progression-free survival, and also patient-reported outcome.
Okay, it's a long debate. in my opinion, it's not the same medication, it's the same class, it's not the same drug. There's a difference. So we will move further because it's a long discussion. The next question also is about what is the role of aromatase inhibitor in general and machine learning specifically in the treatment, diagnosis, and prevention of recurrence of breast cancer, and what are the newest technologies used in the field? I think here the question is about the artificial intelligence. It's not our talk. So because what's the role of AI, artificial intelligence in general, and machine learning specifically? So
Sami Khatib بيجاوب.
Okay, we will skip it after.
Yeah,
So
next
also
time.
to Dr. Naji, to Professor Naji, what's your opinion about Herceptin? I like the question also. What's your opinion about Herceptin plus lapatinib when other agents are not available, like pertuzumab and
yeah, it could be used. يعني, it could be used if the other drugs are not available. And if they have lapatinib and trastuzumab, it has been used in combination, يعني, better effects than having single agent alone. يعني صار مثل trastuzumab beyond progression يعني with lapatinib. It could be used.
We have a doctor raising her hand. Carla, what to do in such case? Because Dr. Karima is raising her hand. Can she speak directly on the Dr. Karima? Can you unmute yourself, please? Okay, we'll be waiting. We'll be waiting. Yes.
الو
الو دكتوره اتفضلي.
شرف عظيم اني اكون معكم، يعطيكم الصحه يعطيكم العافيه. انا دكتوره كريمه من الجزائر.
اهلا وسهلا.
اهلا دكتوره.
Here we don't have pertuzumab, we don't have we just have lapatinib, trastuzumab. We don't have TDM1. So what we do if you don't have TDM1, pertuzumab?
Yes, you can use what you have. Actually, maybe you'd be able only to play with one of them and then change the chemotherapy companion. I would say that your options.
Yes.
Naji, would you like to add something?
Yes. If the patient is having metastatic right from the beginning and the patient was responding very well to trastuzumab alone, then one of the options is to go for trastuzumab as it's available now. And if it's free, you can go for it as long as the patient is responding. I think that this is one of the options that we discussed before with the Professor Naji Saghir. And those patients with metastatic breast cancer in the pre-pertuzumab setting were started on trastuzumab, and then they were responding very, very well. And the option is actually to continue as long as her cardiac status is allowing us to do so. So what's your opinion, Professor Naji?
Naji?
Yeah, I didn't hear the question very well, sorry.
Well, our dear colleague from Algeria was saying that she only has two anti-HER2 therapies, Herceptin and lapatinib.
Yeah.
So she was asking what to do in situations that you need something more than that. How can you play with the two agents she has?
Well, look, I mean, we have trastuzumab, you can use the lapatinib, you can use them in combination. More than that, يعني, I don't know what you can do. هلا طبعا using them beyond progression كمان, not having the drugs, using them over and over again, it's also a big cost to society. So if the government or يعني, ministry does not have money to buy the other drugs, I don't think people should continue to use the same drugs because it's not going to make a big difference. يعني, maybe patients would have to be given only chemotherapy or even hormonal therapy. I mean, you don't have much choices, right? But to keep continuing it, I mean, beyond progression, actually, trastuzumab beyond progression is not approved in every country. In Europe, for instance, it's not approved everywhere. Many countries approve trastuzumab only twice or only once, you know, in metastatic disease. So the best thing is to get the drugs, but maybe to be able to يعني negotiate the price. إذا هي مشكلة السعر طبعا ببلادنا هذه المشكلة يعني. هلا governments, ministries have to be able to negotiate the price and get them with a better يعني deal.
So Naji, what if the patient was responding very well to trastuzumab alone? Are you going to continue?
Yes, we continue, yes.
Right?
That's the recommendation. You continue it exactly as you say. For patients who are responding, we don't know when to stop it. At the ABC5 or ABC4, I think, we had a statement that was approved by the majority of the panel that at ABC5, if the patient is in complete remission, like for several years, 4 or 5 years, you may stop trastuzumab with the condition that if the patient recurs, you can restart it. Because in some European countries, if they stop it, they cannot restart it again. So if you can have the option and the patient is doing well for 4 or 5 years, complete response, you can consider stopping it. But I have to tell you, we have not been courageous enough to stopping it. I don't know if anybody of the other colleagues do that.
I would like to thank you all. I would like to thank also the participants. Just I would like to remind our participants, Dr. Fadi will give us the closure, but just to tell them that to save the date that our next course will be in GI session 1 on June 19th after 3 days on Friday. Thank you for all. Thank you, speakers. Thank you, panelists. Thank you, participants. Please, Dr. Fadi, the floor is yours.
Thank you.
So again, thank you very much, all of you. Just to say for those who had a question, please send it. If you might send it by email, we will answer it. And I'm sorry for that. The next time we'll take more time for questions because we have a lot of questions yet. And we have other commitments, so that's why we have to leave. Thank you. The next meeting is on GI, and you will receive, starting tomorrow, the invitation for the next session. Thank you again, and goodbye. See you hopefully soon. Bye-bye.
May I just say a word and remind you that we're going to have a Best of ASCO July 10, 11. Stay tuned. Best of ASCO in Beirut, but virtually, يعني, July 10, 11.
Excellent.
يا اكشوال يا بلاش مش هيك دكتور علاء.
انا معاك 100%. انا معاك 100%.
ما رحنا على شيكاغو كلنا.
انا طايره مخصوص عشان نروح بيروت لو الطيران مش شغال يعني.
We miss all of you.
ان شاء الله. رب نشوف بعض على خير ان شاء الله باذن الله.
ان شاء الله. اوكي. يلا باي باي.
باي باي مع السلامه.
باي باي.
Au revoir. Bye bye.
باي باي.
Thank you.
Thank you.